Good afternoon, everyone. My name is Sarah McKenney. I'm the Director of Alumni Relations here at NSU. I see some familiar faces in the room, and I'm really glad many of you are joining us for today's Lunch and Learn. Long COVID, Unlocking the Keys to Recovery. A special welcome to those joining us virtually on Zoom. We have more than 200 registered online, which is awesome. And we thank you as well. And thank you, obviously, for those of us here in person. To our LLI students, thank you again for joining us. And we're really glad that you all are here. Before we begin, I just want to acknowledge the team that makes events like this happen. So our Executive Director of Alumni and Annual Engagement, Suzanne Bernardin, is here. Great, yes, round of applause. Our Associate Director of Alumni Relations, Renee Johnson, is here. She helped with your check-in today. And my Assistant Director of Alumni Relations, Emily Lopez Martin, is working behind the scenes, ensuring everything works smoothly for our Zoomers. This topic, as you know, is a very important one. Long COVID continues to affect millions of people around the world. And you're going to hear more about this, obviously, from Dr. Klimas, but also from Danielle DeRoss, who is our marketing manager here at NSU within the Public Relations, Marketing, and Creative Services Department. And she's going to guide today's conversation. Today's program is also a special milestone for the Office of Alumni Relations. This month marks 1 year of the NSU Alumni Lunch and Learn programs. Over this past year, we have celebrated many featured speakers and awesome faculty here at NSU, and we are really looking forward to bringing their incredible work to our alumni and our friends this coming year. It reflects something that we really deeply believe: learning does not end at graduation. Our alumni community continues to stay curious, engaged, and connected to the research and innovation happening right here at NSU. A few quick housekeeping notes before we begin. Many of you are eating already. Thank you. We have the buffet is open, so please continue to eat. Grab some seconds when you're ready. You'll also notice we're implementing a new system for collecting questions. So on your table, there are pens and there are note cards. If any questions come to mind during today's presentation, please write them down. My team will be collecting them at the end. So make sure you have your name on there and your question for us to read when we are reviewing them. It's now my pleasure to welcome our moderator for today's session, Danielle DeRoss. Thanks again, everyone.
Thank you, Sarah. Thank you all of you for being here in person or over Zoom. This is great attendance, and you're spending your lunch hour with us, hopefully learning a lot about a really important topic. I think it's really fitting that we're here in the month of March, because it was 6 years ago this month that we all started to socially distance and shut things down. And for many of us, our lives really changed at that point. And while many of us in the past few years have just tried to move on from COVID-19, put it all in the past and just get back to a normal life, unfortunately, so many people cannot do that, because today they are still struggling with the long-term effects from a COVID-19 infection. As many of you know personally, long COVID is a complex and chronic condition with no known cure. Patients struggle with persistent fatigue, brain fog, tremors, pain, and other symptoms. And what is more is that these patients often feel unseen and unheard and misunderstood as they battle this invisible illness. But one person who does see them, who is fighting for them every single day, is Dr. Nancy Klimas. She is a distinguished professor of medicine and the chair of the Department of Clinical Immunology here at Nova Southeastern University, where she leads the Institute for Neuroimmune Medicine. Throughout her career, Dr. Klimas has been at the forefront of research and clinical care for conditions like Gulf War illness, ME/CFS, fibromyalgia, and now she's leading a clinical trial to find a treatment for long COVID. We're so lucky to have her at NSU. We're so lucky to have her speak to us today. After her presentation, I will facilitate this question and answer. So please come with your questions, come with your appetite, and enjoy. Thank you, and help me welcome now Dr. Nancy Klimas.
Thank you all. I appreciate that. And thank you for letting me be your anniversary speaker. That's pretty cool. And it's great to see all of you here, and amazing to have that many people online. I'm here on behalf of the Institute for Neuroimmune Medicine, part of the team We are a great big group here at Nova. We've grown in the 15 years since we all moved here to create this institute. About half of us are clinicians and half are full-time scientists. So it's a neat group of people that both take care of patients, learn from patients, let the scientists know what we're learning on the clinical side. Meanwhile, they're learning things on the research side that inform us. All together, it comes together when it works perfectly, which we hope it's trying to, into a translational research group. So we make new discoveries. We're able to translate to clinical care very rapidly. And it's a great group. So the Institute, as I said, we're about half clinicians, half full-time scientists, and the clinicians are scientists too. So it's a wonderful group of folks to work with, and we're hitting at this at many different levels. So start with long COVID. As you all know, 2020, big year, and that was the worst year in terms of the most powerful variant. We have many patients who started with their long COVID in 2020, but this illness is still occurring with the current variants. So it's not that it's just, oh, we're past it. We're right in the thick of it. We're in the middle of it. And there are very many people that have been affected. It has a wide range of symptoms. The most common is our fatigue. Now, we're used to this. We've been taking care of patients with myalgic encephalomyelitis or chronic fatigue syndrome for decades. And their predominant symptom is post-exertional relapse, that they push too hard, they reach an energy envelope and it crashes them and they go to bed, they're crashed. And so this is also true in long COVID. There's a lot of things that are similar in this post-viral illness as we see in ME/CFS. In neurology, brain fog, cognitive complaints, memory problems, headaches, cardiopulmonary, a lot of cardiovascular things, since the COVID virus itself attacks a receptor in the blood vessel. And so there's a lot of vascular and heart and lung complaints in the patient population. And then sensory things, including things that are clearly damaged during the acute COVID, like loss of smell that never recovered, that kind of thing. But also a lot of musculoskeletal things, fibromyalgia-like symptoms, total body aches and pains, arthralgias, myalgias. And this is a big one. We use the word autonomic dysfunction, but this is your system that regulates your blood pressure, your heart rate, and so on. So you have someone waking up fully rested with a heart rate of 110. Like, that's not normal, right? Do any little bit and boom, it jumps up 30, blood pressures fall, a lot of dizziness. This is autonomic dysfunction, and there's an illness called postural orthostatic tachycardia syndrome, POTS, the most common thing that we see with these real rapid heart rates with very minimal, even just standing, not even moving. So that matters because it affects blood flow. And then, you know, if you have a chronic illness, the rate of issues around chronic mental health issues is the same. If you had chronic renal disease, about 50% of people would suffer a major depression because it's a serious illness that steals away your sense of wellness. And it's true in any chronic illness that we see depression. But this illness, we see a lot of anxiety because they have this autonomic thing. Their adrenaline system's on all the time. And if that doesn't give you symptoms of anxiety, what will? And then non-restorative sleep is a really important piece. Underneath it all, that's what matters. What can we fix? What's under it? Why does it persist? Why does it continue? And one of the big hypotheses have to do with either viral persistence. Is the COVID virus still going on all these many years later? Or did you deposit enough viral stuff, proteins, that your body's continuously seeing bits and pieces of the virus that keep the immune system all stirred up and active? And that's one of the hypotheses the study that I'm going to show you today is pursuing. But also we do know there's just chronic immune activation, lots of inflammation. The cells that are antiviral don't work very well. The brain has the inflammation, so does the body. The virus, which attacks blood vessels, and so is this viral leftover proteins or spike proteins, the ones that bind to the blood vessel. So that makes the blood vessel an attack space for the immune system to say, whoa, that's not supposed to be there, I'm going after it. And then you create inflammation in all the blood vessels. A big part of this illness has to do with circulation, inflammation in the blood vessels. And then finally, energy itself, the mitochondria in your cells, your energy powerhouses, there are fewer of them and they don't work as well. Some other key mechanisms are the autonomic thing that I was talking about. Why is that going on? Whether or not we have the right neurotransmitter balance. When your brain's inflamed, you don't get the little fine-tuning signals between cells, and you can get abnormalities of neurotransmitters. Inflammation in the brain causes what's called central sensitization. You feel pain a lot easier. A light touch on the skin might feel like fire or burning or a pain, because the brain oversees the pain signal due to what's going on centrally in the brain. And finally, the gut. The gut's a great big thing because there's something called the gut-brain axis. What's going on in your gut is communicating with your brain. And also, the gut is supposed to keep all the bacteria in the gut. Your immune system's not supposed to be dealing or seeing it. But if there's something called leaky gut, then the immune system is dealing with a lot of immune activation, a lot of things that keep systemic inflammation driving. So next, who gets it? Well, everybody gets it. It's not discriminating. However, the people that got the worst of COVID got the worst of long COVID. And so first responders, people that had to work without before we knew about masking and all that, those people were particularly likely to get long COVID. Global prevalence is thought to be 8 to 35%. It's probably really around 8 to 10%, but 10%. I mean, everybody got COVID, right? Practically, a very rare exception. So 10% of the entire global population still has residual effects, and some of them very sick from their acute COVID. That's a great big deal. Now, some people were at higher risk. For instance, women tend to get more of the fatigue symptoms. People who are vaccinated have less risk for long COVID. That makes sense. Less risk for the infection, you get less risk for long COVID. The older you are, the more vulnerable you are. That makes sense. Your immune system is starting to tweak out on you a bit as you get older. And it also likes to hyper-react and be more autoimmune and more inflammatory as you get older. So more stuff going on as you get older. And then if you had really severe COVID, hospitalized COVID, you're at higher risk for long-term consequences. But you could have had no symptoms, just had asymptomatic COVID and get long COVID, which is really something to think about. That's really interesting. Also, people with pre-existing conditions, people who are heavier, people who smoke, and people who have limited access to healthcare and weren't able to access care during the time that they had acute COVID are more likely to have long COVID. And these are the demographics of first responders and upfront people, Black, Hispanic, the people that couldn't go home and work from their house. They had more COVID and they had more long COVID. White populations have higher rates of fatigue and musculoskeletal, so it presents a little more differently. And then there are variant influences. That first year was the worst year. Alpha was the worst, and it had more more damage to smell more than the other variants. Delta has more ENT stuff related to it, but any variant is a good variant for long COVID. Important things, you can be young, healthy, no pre-existing conditions, and you got long COVID. That happens all the time. And reinfection matters. Repeated infections increase the risk of long COVID. I mean, I've had COVID 4 times. Let's hope the 5th one's not the charm. That's a lot. And I've had every vaccine. The long COVID studies here. So we're doing a lot of different types of work as a team, as a group. Remember again that we were already working in this area of post-viral illness and toxic injury. Gulf War illness, people went to the first Gulf War in 91. They had organophosphate exposures. 1 in 3 is still sick today from their experience in the Gulf in 1991. That's a lot of people, very sick. And they present just like this. It looks exactly like long COVID. ME/CFS, typically post-viral, often after mononucleosis, but the flu will do it. Looks just like this. We couldn't tell them apart. The only way we can tell them apart is by asking someone, when did you have COVID? Oh, is that the onset of your illness? Must be long COVID. So that does matter. I was saying what we're doing. So we have a great big study with the CDC. We have 800 people in a longitudinal trial. We're following them for 3 years, looking at outcomes and predictors and so on. Of those, we brought in 200 for deep phenotyping. They come in. Our lab does everything you can imagine to look at their blood, and we do all kinds of things in the clinic to see what's going on. And we have a huge data set pre-COVID of ME/CFS that we did with the CDC, another 750 patients. So the plan is to compare this study to that study and be able to have a better understanding about what's the same and what's different. But most importantly, I think we also should know predictors of outcome. Who's getting better? Who's getting worse? What's the predictor? So we can focus on the right parts. We're doing this study I'm going to describe today, this monoclonal study. We're doing a study at the University of Miami looking at the blood vessels and how to help them heal. And we're doing a study with some people at Oxford to look at the way antibodies are made and why you can't sustain your immune response to COVID. Why is it you keep needing to be vaccinated over and over again? Your antibodies aren't sticking. But the people with long COVID have the worst problem with not having long-term immunity after COVID that's effective. So to speak about our monoclonal study, it's an antibody against spike protein. So our hypothesis is people still have spike protein in long COVID. And there's some serious data to support that. I'm going to share that with you. And it's a moonshot because if you think about it, you can go after COVID the way we do clinically, trying to tease apart all the bits and pieces. I call it peeling the onion, take care of the autonomic piece, the inflammation piece, the so on and so on, and try to help people feel better. Or you could get at the root cause. And I always use HIV as the example because I was there at the very beginning and all the way through. And we were treating HIV like peeling the onion. We were treating anything we could until we figured out the cause was actually HIV and we could remove the virus. And what happened was in HIV, the people who were almost dead had complete recoveries, complete immune restoration. All those incredibly broken systems came back because we're programmed to heal. Our bodies want to heal. So if you can get at the root cause, if there is a root, if there's a single root, then go for it. So this is the moonshot. Is the single root either persistent virus or residual bits and pieces of virus, proteins, spike protein specifically, that are causing the bottom line, are they causing long COVID? So spike protein has been linked, being able to measure spike protein in your bloodstream with long COVID is linked to the severity of symptoms. It's linked to the amount of inflammation that we can measure. It's linked to the amount of endothelial dysfunction that we can measure. It's associated with the specific symptoms of brain fog and fatigue and cardiovascular symptoms. Very importantly, it's been found deposited in the bone right next to the brain, in the corpus callosum, right next to the brain, in the area right in front of your sinuses and in your skull itself, deposits of spike protein, which would make you worry about neuroinflammation. It's seen in the plasma in the blood, depending on the study, maybe 30% of the time, maybe 60% of the time. But with an assay that had the old assays really underestimated, the new assays are more sensitive. So it might be higher still, but it's higher still when we look in solid organs. So blood might not even be the right place to look. So is it in everybody or is it in a subgroup? It's one of the questions our study hopes to answer. I talked about immune activation and driving immune activation, and it's being sequestered in tissues and in hard tissues and in bone, and that we're having trouble measuring it. There's no clinical assay that I can order on one of you right now today to tell you if you have spike protein circulating. It's just a research tool right now. So what do we know? That people with long COVID have maybe have an abnormal immune response. Their antibody levels to COVID, which you would expect to be quite high if they have persistent antigen, they should keep making antibody. In fact, they fail to do that. And so, oops, I thought I put that slide in. A colleague of mine, Dr. Andrew Shaw, and this is his data from Oxford. He's really an amazing guy. He has an assay that looks at every single variant. This is actually clinically available. And he can tell that 65% of people with long COVID didn't hang on to their antibody response. It faded very quickly. Whereas 10% of people have way too high an antibody response. These are the people he presumes to have the vaccine injuries, the people that have the hyperimmune response that get sicker when they get vaccinated. They might be in this 10%. And then 25% look normal. So who are they? And what do we do for them? So perhaps in the study I'm going to describe, I'm going after that 65% that wouldn't be able to have sustained their antibody to spike protein. So he would suggest the interventions be immunotherapy, like I'm proposing in the immune compromised people, and in the hyperimmune people, calming down the immune system, not beefing it up. The completely opposite button. So it's important to know as a clinician, if I push the wrong button and it's random, if you're the 10%, you'd be really sorry I tried to turn that on. But if you're in the 65%, I sure don't want to use something that would further suppress your immune system as a treatment. So it's important we know the difference. So this is our study. Sipavibart, it's the AstraZeneca product. You might remember a product called EvuShield during the pandemic that people took to prevent COVID. It was very effective. It's made from the B cells of people who have recovered. B cells are the programmers for antibody. So they collect B cells from recovered people. And then they've done that over the various variants, and they keep upgrading their product. The last time they did this was a year and a half ago. So for variants up to a year and a half ago, this product covers them, all of them, the alpha, the beta, the delta, and the early Omicron variants are all in this product. So they made this product. And the other thing about the product is that it lasts 6 months, a single injection. So they made it so that it didn't get removed by the immune system, which is pretty clever. So we're doing this study. It's with this drug. It's long acting. It's made from convalescent patients, and it neutralizes all these variants. It's a classic study, group A, group B, 50 people in each arm. And we're following them for a total of 6 months. And then at the end of 6 months, anyone in the study can have the real thing. So it's not a classic crossover. It means that everybody knows they really got the drug on the 6-month mark. There's no, it's not placebo control blind, but it gives everyone the opportunity to have the experience of receiving the drug, which we're grateful to our study subjects for volunteering, and it gives everybody a shot at getting this drug that's not approved in this country, so we can't get it for them. So it's only happening here. This is the site. The idea is to check safety, and also efficacy on symptoms. But it's also this study that's collecting everything we can think of: blood, saliva, stool, everything we can think of, because we intend to do a really deep dig. If this is an effective drug, a study drug, and we don't know where the virus is, what if the best place to find it is in the GI tract? Well, then the stool sample might be the best place to find the reactivation. And so even though this study isn't really funded well enough to do everything we wish we could do, we at least collected everything, and then we can go back and try to find the money to dig deeper. So there's a lot of exploratory biomarkers, then a lot of tests we plan to do, and then others that we hope to do if we get the money. So, but we are measuring spike protein with that research tool at Harvard. The Harvard labs are doing that for us. Our lab is doing all this inflammation markers, cytokines, and all the flow cytometry. University of Miami lab is doing endothelial function, which is the cell wall of the blood vessel, looking at the cells that are the very, very broken in long COVID to see if they're healing. And then this big biorepository I talked about. So that's the study. It's underway. We're about a third, almost halfway recruited. We plan to be fully recruited by June. We have to be. If you want to learn more about it, it's on our webpage, and there's a way to register or get more information on our webpage. But it's not the only study we're doing, but it's the one I'm talking about today. Wait till the end. So So we have other things, just people want to know what else can you do for this illness. You can do this. This is, we're interesting clinical group. I mentioned that we're a clinical group. I think we're the only group in the region that actually specializes in post-viral illness. And there's 8 clinicians in the group. We're interdisciplinary, multidisciplinary. I'm an immunologist. We have integrative medicine, environmental medicine, functional medicine, osteopathic medicine, functional nutrition, oriental medicine, all of that is in our group. And we all meet every Friday and discuss all our cases. So if you come in through one door, you sort of see everybody, which is pretty cool, indirectly. So we're probably the place to go, I think, if I were in South Florida, without bragging as I should, that this amazing team that we've assembled. We are the place to go. So, and we target these things because even if we don't have clear clinical guidelines, and there are no guidelines yet on how to treat long COVID, short of how not to hurt people further, that's the physical therapy guidelines. But because if you push people too hard, they will get worse. But we target everything we can. So trying to improve perfusion, strategies for that, and make the autonomic nervous system stop being so driven by adrenaline. There's strategies for that. Viruses reactivate and actually predict who's sickest, like EBV, mononucleosis virus reactivates, CMV, HHV6, all reactivation viruses. There's strategies for that. And then trying to figure out who's autoimmune and put them into the right bucket so that we can approach that. We have the world's foremost authority on mast cells. Dr. Theoharides is a part of our group. He's amazing. And he has a lot of work done on whether or not this isn't the most important of all the cells mediating this illness and ways to make that cell behave itself. And he has a once a month clinic with our group. And then these other kinds of things that we're looking at. Mitochondrial function is a really big one that we also can approach clinically. So there's a lot going on, as you can see. I just scrape the surface of what we're doing, 2 of our biggest studies, but we have a lot of other studies in the wings that we'd like to be doing. I'm going to say thank you for your taxes. You paid $1.15 billion into the long COVID bucket at the NIH, and much of what we have learned, it comes from that investment. To give you an example, at MECFS, there wasn't a year that they spent more than $12 million in the last 30 years of my doing this research. So you can imagine what those decimals mean to progress. It's extraordinary. And at this point, we understand that there's a lot of mediators, that they're targetable. They're very focused clinical trials are going on, that we're subgrouping by what we're trying to fix. That's really important. If you lump everyone together, every trial will fail. And so, because they're a mixed heterogeneous group, so that's not going to work for everyone. So trying to circle the group that's going to respond to that particular intervention is rather important. And that's certainly a strategy that people are doing. And we've been really lucky to have the Schmidt Initiative for Long COVID funding a big part of this work, as well as the Florida Department of Health and the CDC for that other big study. The Schmidt family is the Google Schmidts. So they have significant funding that they're putting into this internationally. They're an international research group. So thank you very much. With gratitude to the many people that are participating in our studies. And if you're online, thank you, thank you, thank you, thank you. If you're in the room, I'll thank you personally. And to our amazing team doing this work and letting me represent the whole group. Thanks.
We had a record-breaking number of questions submitted already. So we will not get to all of them, but we'll do our best. Dr. Klimas is very humble, but I think we should note that she is one of the leading experts on this across the globe. So we're so fortunate to have her. My question for you, based on your expertise, based on everything you see and you see firsthand, how optimistic are you for a treatment for long COVID someday?
Oh, so let me just say that investment matters. This amazing amount of money that have been put aside to try to understand this illness has already created an extraordinary amount of information and resources. There are 15,000 people in a biorepository with longitudinal data that have been collected through the Recovery Initiative, which is the NIH space, and a tremendous amount of work around that. So we're in our field, MECFS, with mini money, we were publishing on N's of 50. You'll pick up a article and it's an N of 750. Definitive, done, nailed it. Don't have to go back there and look at that again, right? Doesn't need any further validation. Where we have a lot of studies in MECFS that still need to be validated because there wasn't enough money to do a great big cohort. So, so exciting that there's already so much knowledge. It's already being translated. The Schmidt Initiative has many clinical trials. If you go into clinicaltrials.gov, which is your best go-to place ever to look for any trial, because it's required that we put if we're funded, we have to put it there. So you'll see there's more than 100 clinical trials in long COVID. If you looked at MECFS as an example, I think you might find 30 in the last 30 years. Versus 100 right now ongoing. So that's really important to understand, and that they're being designed correctly and they'll give clean answers. So I'm very optimistic for long COVID. Now I am also optimistic for MECFS because it's riding on the tails of long COVID. There's much to be learned from long COVID that will matter to MECFS in a very large way. So whether or not we'll be able to generalize or get to do that other study that needed to be done to confirm, but we'll at least have a lot of the work being fronted by the long COVID efforts that should help us with these other illnesses. I'm going to say the same thing for Gulf War illness. It also needs all this, and we will also ride the tail of the long COVID advance.
One of the most popular question that we received on our Zoom registration was about two very prominent symptoms that people experience. Long COVID patients who have fatigue and brain fog. And a number of people just asked, what do you recommend for those patients, generally speaking? We know you're not their doctor and can't give them personal medical advice, but when you hear about those symptoms, what are the general pieces of advice?
So to understand brain fog is to understand the pathophysiology of the illness. It's coming from three things, and they're interrelated. Not enough blood flow. When the brain doesn't get blood flow, it has to switch from using oxygen and glucose to make energy to an anaerobic system, which makes a tremendous amount of oxidative stress, no matter what your age is. And normally we don't see oxidative stress in young people, but you do in long COVID and MECFS and so on. So oxidative stress in the brain. Oxidative stress drives inflammation. So then you have neuroinflammation and vice versa. Inflammation drives oxidative stress. This great big vicious cycle of not enough blood flow, too much inflammation, a lot of oxidative stress. So as clinicians, we can attack whatever we can attack. We attack oxidative stress. That is not too hard to do. There are many, many nutritional ways of doing that. And there are ways of doing that with supplements. The main thing, knowing that they cross the blood-brain barrier and get into the brain. So there are some, like NAC, N-acetylcysteine, crosses the blood-brain barrier, while glutathione does not. But NAC leads to glutathione, and that's what you're looking for. So we use a lot of that type of thinking. What gets there that would do the job? And what's the evidence from other illnesses that we're using the right thing? So like in Parkinson's disease, those trials have been done. And so we can say, yes, you can use this, and it goes there, and it does that. And so we have to borrow from what's been done in other illnesses. So we treat oxidative stress. We treat inflammation. Inflammation is hard to treat, and it's a little more complicated in long COVID because there's more than one kind of inflammation going on. But there are strategies to reduce inflammation with nutrition as well as with supplements and with medications. And then finally, perfusion. Perfusion. This is the most important piece of this. The microcirculation in long COVID is really poor. And there are no clinical trials yet to tell us what to do. We treat microthrombi. That happens when the blood vessels are inflamed and they start a bunch of little tiny clots. And so there are ways to treat these tiny clots. There have been a few trials for that, so we borrow from that knowledge. They're not easy to treat, but they're treatable. But we also want to pop open those vessels. And again, there's some foods, nitric oxides in beets. I mean, you can really increase the foods that have things that are vasodilating, like nitric oxide, or you can take supplements that do that as well. And we're doing a trial at the VA. I should say we, it's Leo, Tamara is an anaplasia. I take credit for everybody's work. It's bad. But they're doing, and Elizabeth Bast. Yeah, they're amazing folks. But they're doing a study with Cal Roy Sciences on a product called Arterosil that repairs the endothelial wall, or at least we think it does. So that study's underway.
We have lots more questions. So, we're doing great on time. So Trevor on Zoom had asked, when you were talking about the spike protein and how the monoclonal in your clinical trial will address that, is there a test for the amount of spike protein that somebody has? And why wouldn't there be a test for something like that?
So yeah, there is a test. It's called SIMOA, S-I-M-O-A. It's a method, a SIMOA method for spike protein. As I say, right now it's a research tool. It's been almost to the point of being in a reference laboratory, but not quite yet. I keep looking because I keep thinking Harvard's going to flip it into their lab any day now. But right now it's not available to a patient. It is available as a research tool. I think it'll be out soon. The other assays for spike protein weren't sensitive enough, and they're probably not worth ordering. That test, though, for antibodies that I was mentioning is a company called Attomaker, Attomaker. They're in the UK, but they accept clinical samples. I think it's $300 to have their assay run. And that's interesting. I don't know. I mean, I know what it means. I don't know that every doctor you brought that back to would understand what that report meant. But we're doing the research, so we're kind of clued in.
Also on Zoom, George wanted to know if you could speak to long COVID in children. How different is it? How concerning is it? You a long sigh just now. So tell us what you know about that.
Kids are so hard. Do you guys are familiar with there's something called pandas? It's a condition, or what's the other name for pandas without the PANS? Thanks, PANS. Thank you. It often happens after strep throat in a child, and it unmasks people with genetic predispositions to be tremendously overactive in their immune system, and it ends up in kids with psychiatric manifestations and profound fatigue and so on. And so we've seen this PANS in these long COVID kids, and so we're kind of concerned that there might be a new wave, a new trigger for PANS. So that's one thing. In our study that we're doing, I tried to bring it down to 14 years old because the safety data was done down to 14, and the FDA made me put it back up to 18. But as soon as we get some safety data out of this group, then I'm going to amend the protocol and try to extend the study to younger and to older. We only went to 70, and I think it's even more important above 70 than under 70. But the safety data was only available to 70, so I had to stick with what the FDA had to review. But anyway, with kids, PANS is one thing, but otherwise they're just like long COVID people, and we're treating them very similarly. They just need a lot more social support. The school needs to understand. You need to do a lot of homeschooling. It really affects the family dynamic. You'll see a kid that is getting all the attention because he's sick, and the whole family is disrupted. And so there's just a lot of complicated stuff to having a really sick kid.
One question that I've always had is what makes so many people seemingly recover fully after a COVID infection, but then some people, 10% of the population, develops long COVID? It seems like it's kind of a luck of the draw kind of thing, or a bad luck of the draw, but is there any sort of common denominator that you know of, or reason why some people get long COVID and most people don't?
So if our hypothesis is correct, the people who didn't cleared the virus, right? Their immune system did its job correctly. Let me also say, this is weird to suggest that COVID is persistent. COVID is a coronavirus. Coronaviruses are 1/3 of the common cold. It's a very common virus, and you do not think of it as being able to persist. It's not supposed to. It's one of those viruses you get rid of all the way. Hepatitis, you can't get rid of. HIV, it sticks around. EBV, it hangs on. shingles, the chickenpox virus hangs on. There are viruses we know are latent long-term infections after you have your primary infection, and everybody pretty much keeps them. But coronaviruses, I mean, that would be heresy in the infectious disease way of thinking to suggest a coronavirus stuck around. And yet here's this data. And I'm saying it's spike protein, but one of my slides buried a single line there that said, and there's another group that's been looking at the kind of RNA that would only be there if it was replicating, and it's there. So that would suggest replicated virus persistent infection, not just old reservoir of peptides.
Another common question that we got over the Zoom chat is just a sense from patients who don't know who to turn to. They say they can't find a doctor that understands long COVID or is able to treat it. What advice would you have for somebody who's looking for that provider to help them?
Well, you happen to have one of the internationally famous groups right here at Nova Southeastern. Seriously, we get referrals from Singapore is the furthest one away right now. We have a whole European group of patients that we care for by virtual, and they come to visit if they can. So I always think that we're the best kept secret of South Florida because everybody else knows about us. Half of my patient base flies in. Half of my patients fly in. I don't have that many local patients. But like I say, we have 8 clinicians. Violet is one of them right here, and Irina, and we were just a terrific group of people. I counted up our years of MECFS experience once, and it was 300 years between us. It was crazy. It was an insane amount of experience because, and I'm also going to just take a moment because Violet is here and Irina is online and brag on them. When these guys joined the team 14 years ago, since then they've added 4 master's degrees, a doctorate degree. If they needed to learn something, they went and got a certificate in that or a master's in that. So you'll see that we have people who are I even added a degree, and I'm too damn busy to add a degree, but I added environmental medicine to my list of things that I'm certified in now. It's because we needed it. You look at a patient and you say, what do I need to learn to be a better doctor for you? And that's really cool that we have that kind of team.
So your team could take on more patients and you could also enroll more people in this clinical trial?
Oh, yeah. So yeah, we are taking patients. You might have to wait a little bit because it's not tomorrow, but we haven't closed the practice. So we see patients, and the trials, there's an online site on our website, Institute for Neuroimmune Medicine and NSU, you'll find us easily. And it just registers to stay informed about the trials and to pre-screened for any study. It gives us permission to call you if you're eligible for something that we're doing. So just go on there and you'll get on the newsletter and you'll know what's happening and all that.
And now I'm going to transition to Sarah, who's going to lead us through the last 10 minutes of questions that you all submitted in the room.
Yes, thank you. So these are in-room questions, Dr. Klimas. Can inflammatory diseases like IBS be linked to long COVID?
Oh, yes, absolutely. We see, well, we say 2 different, irritable bowel syndrome, which is different than inflammatory bowel syndrome. They're 2 different diseases of the same initial. We see IBS, irritable bowel, all the time because it's dysautonomia. It's all about the motility of the gut. And so it would be kind of hard to almost see someone without irritable bowel. It's hard. We're doing a study at MECFS where there has to be a group without it, and they're hard to recruit because everybody has it. So that's a neat study with a pro and prebiotic. So inflammatory bowel, we definitely are seeing de novo new cases, and they're in the literature for that, like brand new cases of people who didn't have inflammatory bowel before, but after COVID they did. When I had acute COVID, I had an acute GI bleed during my week of my alpha COVID. I needed blood. That was pretty damn scary. That was a COVID ulcer. Yeah.
That is scary. Glad you're okay. Can long COVID impact your blood cell count?
Yes, indirectly. Vacate the building? Did we do something? Oh, that's an Amber Alert. It's an Amber Alert. Okay, we got it. All right, so anyway, you're asking whether or not
The question was, can long COVID impact your blood?
yeah, so yeah, it'll affect your white blood cell count always, in some way or another, usually kind of subtly. Red cells indirectly, we do seem to see a lot of iron deficiency, and that might have to be something to do perhaps with GI bleeding, but perhaps also with absorption. So I think we do see changes in the cells, but they're not diagnostic. You couldn't say, that's the long COVID pattern.
Any clinical markers to confirm CFS/ME?
You were out there and in here. Clinical markers for ME/CFS. It's a total clinical case definition, meaning it's your history that tells me whether or not you have ME in your presentation, the symptoms that you have, whether or not you have it. It has a very clear case definition. It requires post-exertional malaise, feeling sicker if you push too hard, and then at least a symptom or two from a list of autonomic and inflammatory symptoms and cognitive symptoms.
Thank you. I think it's an Amber Alert, everyone. I think we're all okay. Oh, it's a smoke in the air. Thank you. Yeah, whoever's in here, no smoking, please. Okay. Does the antiviral Paxlovid help lower the risk of long COVID?
What a good question. So Paxlovid, first there's a trial for Paxlovid underway right now for long COVID. The first one failed. It gave 2 weeks of Paxlovid and it didn't impact long COVID. But now there's a longer one, you need to take it for a long, it makes sense. It doesn't make sense that you could clear this infection with 2 weeks of Paxlovid if it's a long-term persistent infection, but particularly if it's stuck in tissues where things can't penetrate. All right. But did Paxlovid at the time you got COVID influence it? Maybe, because we know people that were at the most severe end are the most at risk. So if it damped down the severity and the length of your acute COVID, it might have reduced your risk.
Is peripheral neuropathy of symptoms of long COVID? If so, is there any treatment?
So there are different kinds of peripheral neuropathy, but there's something called small fiber neuropathy that's extremely common and is actually the underpinning of a fairly high percent of people with fibromyalgia. So whether it's long COVID or not, fibromyalgia has this small fiber neuropathy as one of the biggest subgroup of fibromyalgia. And it definitely happens in long COVID. It definitely happens in ME/CFS. We know that. And so for that, is there a treatment? Two schools of thought. There's a school of thought by Dr. David Systrom in Harvard who thinks the original injury was ischemic, that the blood flow didn't get to the nerve and that killed the nerve. That makes sense. It's the most further out there. It's in the skin. If your microcirculation is terrible, it's going to be picked up in your sensory fibers first. And in which case you're chasing it if you start treating it as an autoimmune disease, if perhaps what you need to do is improve perfusion. On the other hand, there's a whole group out of Germany that's got all this autoimmune data on small fiber neuropathy, particularly in ME/CFS, that says there's actual antibody against the small fibers. And then the treatment would be depleting antibody in all kinds of ways. And they're doing pheresis studies and B cell studies. I just talked with her yesterday on a Zoom thing, and they're doing 3 different avenues to try to get rid of these antibodies.
I think we have time for maybe 1 or 2 more. This is a name that I might not be able to say correctly, but there's someone named Diane Coward who runs the quote Physics Girl YouTube channel. And she was disabled by long COVID for 3 years and only recently started producing new videos. Are there other high profile examples?
Oh my gosh, there's so many of them. I know the ME one's better because I'm always trying to get them to do fundraisers. That hasn't worked out yet. There's some pretty famous people there. Um, I mean, there's so many people just went completely out and are drifting back. I mean, I would have to Google search it, so Google search it. But it just hit everybody, I mean, 10%, it's out there, it's everywhere, And as I say, when you see these family foundations starting to kick in money, well, you don't know that they're beautiful people that are doing that, but I bet you there's a family member that inspired that level of dedication.
This one's very specific, and so we know you're not everyone's doctor, but this is regarding the forehead bone. If the spikes concentrate there, is someone who has had that bone replaced or compromised at greater risk of developing severe symptoms if they contract COVID?
I have no idea. Certainly the plate can't get it because it doesn't have any perfusion. So if they put a metal plate there, that part's good. But I don't know if the local area that's generating, I mean, it's just more solid bone. I can't think why that would be more of a risk. I don't think so.
Awesome. Well, we have a couple more, but they're a little very specific. So I know you're potentially able to spend a couple more minutes with us. So we thank you for that, Dr. Klimas. And I just want to take this time to say thank you all for attending today. And we really appreciate your attention and your interest in this topic and interesting to hear it from our leading faculty research here at NSU. So thank you for taking the time. Thank you, Danielle, for moderating a wonderful session. And obviously, thank you to Dr. Klimas for all of your research and expertise. So if you have questions to my Zoomers that we might not have addressed today, please email alumni@nova.edu, and we will do our best to make sure they get to Dr. Klimas, or we can figure out a way to answer them. So thank you for everyone on Zoom, and thank you to my participants here. Have a great rest of your day.